very good morning to all of you, and I highly appreciate that you have taken time out to gain some knowledge and information about this very common disorder in pediatrics. So I will take you back in time. 2000 years back, if 1000 years back, if somebody had seizures, it was considered as wrath of God. There used to be no medical treatment for seizures. Over the centuries, treatment evolved. Medicines were discovered and the treatment focused to control of seizures in epilepsy. Now we are in the 21st century. And the whole philosophy of the management of epilepsy has changed from controlling just seizures to making a child productive citizen of tomorrow, where he can live a productive life. He can contribute his part to the society. So therefore, this is a huge change in the whole philosophy of epilepsy. And I begin with this very small message, is that epilepsy is not only about fits or seizures. There are several dimensions to epilepsy. Children with epilepsy have many other problems apart from seizures, which I will be talking briefly about. And this initiative by Nai Disha to empower parents with knowledge goes a long way. How? Because the treatment now has changed from unilateral doctors writing prescription, going home, to parents becoming active partners in treatment of their children, and parents being equipped with the right knowledge to take informed decisions. I am a doctor. You come to me with a child with epilepsy. I tell you that these are the possible options of treatment. These are the plus and minuses of each treatment modality. And I inform you which one, and I leave the decision to you as what will be the best for you. Why I am talking about this? I will be talking in the next 15-20 minutes. Why this talk? I have already talked about it. Is a common disorder. If treated well, children can be very close to a normal life. If mismanaged, the situation becomes very bad and progresses from bad to worse. So now is the time that all parents are equipped with the knowledge so they can take the right decisions for their children. They can discuss the problems with the doctor. Next, please. So all of us might be having this confusion as to what are fits, what are seizures, and what is epilepsy. Are we all clear with this? What are seizures and what is epilepsy? So seizures are basically fits in our common language. These are nothing but they are brief periods of alteration, some change in symptoms because of the abnormal electrical activity in the brain. Our brain consists of many cells known as neurons. So these neurons communicate to each other by electrical signals. So when these electrical signals become abnormal, they are very high or they all fire together, then we get what is known as a seizure. Seizure can manifest as stiffening of limbs, uprolling of eyeballs, frothing from mouth, jerky movements of limbs, brief lapses of alertness or consciousness. These are of various types. But all seizures are not epilepsy. So epilepsy is a condition in which you have more than two or more than two seizures, which means that the tendency to have frequent or repeated seizures, that is known as epilepsy. So an individual can have one seizure, but when it becomes 5, then it might be epilepsy. So as we know that it can present at any age, but it is more common in childhood because the brain in infancy and in the newborns is immature. And an immature brain is more likely to have epilepsy than an adult mature brain. So therefore, the data tells us that 60% of epilepsy has its onset in childhood itself. So the disease in 6 out of 10 individuals starts in childhood, right? And just to put into the context how common it is, more than 10% of population are at risk of having at least one seizure in a lifetime. That means 1 in every 10 people have the risk of having a seizure in their life. And 3 to 4% go on to have epilepsy. That means 2 or more than 2 seizures. And all over the world, it's 50 million people who are affected with epilepsy. And to this burden, 3.5 million people are added every year. So what causes this epilepsy? Why this abnormal electrical activity in the brain? Why does this happen? So the causes can be several. Epilepsy is more common in a damaged brain. The reason for damage can be infections. Somebody has got a brain fever, what we call meningoencephalitis. Somebody got a head trauma in a road traffic accident. A baby cried late after birth. So the oxygen reached the brain late. That brain also gets damaged. There are certain genetic causes of epilepsy. And there are some structural malformations. The brain has not formed properly since birth. They can also have epilepsy. So what I am trying to say is that epilepsy is not one single disease. It is a disorder consisting of several different types of epilepsy. Before we come to the diagnosis of epilepsy, it is important that we recognize what is a seizure. So seizure can be something tonic, which means stiffening of limbs, absence, which means brief lapses of consciousness. A child would do some activity and get lost for a few seconds, blank or vacant for a few seconds. Even these can be seizures. We are all aware of generalized tonic-clonic seizures in which there is violent jerking of all 4 limbs. Myoclonic seizures, which means sudden jerk-like movements of the limbs. So these are the different types of seizures, and it is important to recognize in the first place that the child has seizure, because only then we would seek care, isn't it? Next please. So what all could be a seizure? I have made one slide on this. Any blank stare, any jerking movements, any twitching of face, frothing from mouth, clenching of teeth, involuntary passage of urine and stool during an episode of unconsciousness, and unresponsiveness. These can all be what we call a seizure or a fit. But then there are several disorders which present like seizures, like fits, but they are actually not fits. It is also important to recognize them, because a child should not be started on medicines for seizures if he is not having seizures. So there is something known as breath holding spells. A child of 2 years old, an infant, a young toddler, will cry, stop for his breath, turn blue and become stiff. These are known as breath holding spells. Frequently parents come to us saying that my child has a fit. And then we go back and ask them under what circumstances the child had this episode. This is what we come to know. And the child would already be started on 2 or 3 medicines for seizures. So it is important to recognize what is seizure on one hand, and at the same time we should know what is not a seizure. Then there are episodes of fainting also, or brief periods of unconsciousness, which is at times syncope and not a seizure. There can be problem with the rhythm of the heart, which prevents blood from reaching the brain. Even that would cause brief loss of consciousness, but it is not a seizure. There are few other movement disorders which I would not go into the depth, which can also present as seizures. So what I am trying to say is that there are several movements which look like seizures, but they actually may not be seizures. So one small message I want to give is, whenever you have a doubt that the child has some abnormal movement, try to video record it. Then you can show it to your doctor, who can then have first-hand information of what actually happened during that episode. So this is one of the smart uses of smartphone, I would say. Next please. So how do we diagnose this condition? So primarily this is a clinical clinically diagnosed condition, but there are few investigations that can help us in reaching a complete diagnosis and plan management. So one of the most commonly used and abused investigation is EEG. I'm sure you must have heard about it. Just like ECG is the record of electrical activity of the heart, EEG records the electrical activity from the brain. Go back to that slide. So this looks something like this. This is nothing but this is the graphical record of the electrical activity of the brain. Sometimes, although the child has epilepsy, the EEG may turn out to be normal. That does not mean that the child does not have epilepsy. So what the important message is that a normal EEG does not rule out epilepsy. It does not tell you that the child does not have epilepsy. Then what is the use then? Next slide please. It would support your diagnosis of epilepsy. It will help you know the exact type of epilepsy. Knowing the type is useful because it helps the doctor in planning the right medicine for epilepsy. There are several medicines available for fits or seizures. Which one should be used depends on which type of epilepsy the child has. So EEG helps us in classifying what type of epilepsy the child is having and help us in planning and selecting the right and effective medicine for that particular type of epilepsy. Okay. And as I told you that EEG will not be useful to exclude the diagnosis of epilepsy, right? Then when do we do an MRI for epilepsy? You must have been advised by me, by other doctors to do an MRI for child has epilepsy. So the MRI tells us about how is the structure of the brain. Is there any structural problem in the brain? Is there any small tumor? Is there any problem in formation of the brain? So the MRI gives us some idea whether or not the structure of the brain is fine or not. So that again tells us what is the reason for epilepsy. Next please. There are few special investigations that we do on a case-to-case basis in epilepsy. These are some of the advanced investigations like a metabolic profile consisting of amino acidogram and other tests. Sometimes there are abnormal birthmarks, white or brown colored patches on the skin, what we call as the neurocutaneous syndromes, for which we do both neuroimaging as well as genetic tests. Apart from that, there are few other tests which we do based on what is the presenting symptom of the child. Next please. As I told you at the onset that epilepsy is not about seizures alone. There are many other problems associated with epilepsy. We call them comorbidities. So what are these? These are behavioral problems and learning problems primarily. So a child with epilepsy might have features of inattention, stubborn behavior, a defiant behavior, somewhat aggression. And then there can be learning problems in school in the form of poor memory, poor attention, and then he may not do well in school and have poor grades. Hyperactivity again is one of the very common comorbidities, and they are often slow learners. So this all depends on how well controlled the epilepsy is. So a child who has no seizure or hardly 1 or 2 seizures in 1 or 2 years will have less of these problems versus a child whose epilepsy is uncontrolled, is having daily seizures. He is likely to have more behavioral and learning problems. So we need to address these problems also while we are trying to manage epilepsy. Next please. Then what are the treatment options we have? But why to treat in the first place? We need to treat because frequent seizures, long seizures, prolonged seizures, they damage the brain. And the long-term implications of this is that the child will have less intelligence, will have more behavioral and learning problems when he grows in age. So it is important to control epilepsy, manage the epilepsy in an optimum way because it has long-term implications. What are our goals? What am I trying to do with treatment? I am trying to achieve seizure control. I'm using the word control and not freedom, because seizure freedom would come at the expense of medicine related side effects also. So on one hand I have seizure freedom, on the other hand I have drug related, medicine related side effects. So I need to strike a balance between the two, wherein the seizures are not debilitating, not impairing the child's quality of life. At the same time, the medicine should not be such that the child continues to sleep for most of the time of the day without learning new things. So what principles we follow? We start with one medicine in the beginning. We start with low dose, increase the dose depending on the response. And if still the child has seizures, we add or change the medicine. This is one thing that I would like to emphasize upon, how to give the medicine. I will cite one example. There is a medicine known as phenytoin given for fits. Are we aware of this? One of the medicines. So it comes by different brand names. One of it is DrAnil's, the other is Aptoin. Now if I write syrup Aptoin 5 ml twice a day, and you go to the pharmacy and buy the other brand DrAnil's, see what happens. This has 30 milligram of medicine in 5, whereas this has 125 milligram in 5. That means if you give DrAnil's instead of Aptoin, you are giving 5 times the actual dose. So be very careful about what you are buying from the pharmacy. If there is any doubt, take back the medicine to your doctor. Make sure that this is precisely the medicine which we intend to give to the child, because this is what it can do. And we have had several children who come to us with Aptoin toxicity, phenytoin toxicity, because of this problem. So be careful about what we are giving to children. Then there is another tendency that the syrup is measured in teaspoons, which is not the right practice. If we prescribe 3.5 ml, you should use a 5 ml syringe to measure 3.5 ml precisely. Using the caps, using teaspoons is going to cause inaccurate dosage. One very simple thing, often repeated thing, is shake the bottle before use, but often forgotten. What happens? The medicine settles at the bottom. What goes to the child is only the sugar portion, which is not going to control the seizures. Something very simple, but often forgotten. That's why I put it. And never start or stop medicines on your own. No matter how much knowledge we might have about this condition, please don't try to self-medicate your child. And whenever we try to stop the medicine for seizures, it should not be stopped abruptly. That means you are giving today, you are not giving tomorrow. It's not like that. Even if you have to stop, it has to be very gradual tapering, which will be advised to you by your doctor. Likewise, in a very small child, an infant, say 1 year old, 1.5 year old, you use a calibrated dropper, give small amounts of medicine, and sometimes medicines may not be available in the syrup form. You can crush the tablet, sprinkle it on food, or dissolve it in water and give. It is very important that you do not hesitate to ask questions. Don't hesitate to ask your doctor, what is this condition? What is the type of epilepsy my child is having? What is the immediate treatment? How do I prevent injuries? In which school should I put my child? What care should I take at school? What about his participation in sports? Can he swim? And always maintain a seizure diary. Now this seizure diary is actually a kind of a seizure log. That means you maintain a record of what is the number of seizures that the child had on one particular day, and what is the type of seizure, and for what duration the child had a seizure. So you need to maintain a record of this and show to the doctor whenever you go for follow-up, so that having a glance at that record, he can make out how much controlled or uncontrolled the epilepsy is. And we have tried to give you what is known as the seizure ID card. Are all of us having this? Yes. So just have a glance at it. Yes. So this contains the details of the child on the front and what to do when the child has a seizure. What is the first aid to be given? So this card can be very helpful. Supposingly the child is in a situation where there are strangers around. Somebody who comes to read this card when the child has seizure can provide first aid en route to the hospital before reaching the hospital. This can actually be life-saving. So I humbly request all of you that if your child has epilepsy or he has recurrent seizures, please keep this seizure ID card with him or her. This can be very useful at the time of seizures when they are not expected. As it is, they cannot be predicted. Next. At times, despite many medicines, the seizures are uncontrolled. We call them medically refractory epilepsy. So what are the treatment options in such severe epilepsy which are not responding to medicines? Next. So we need to go back a little and ask why the epilepsy is not manageable. Why is it uncontrolled despite medicines? It can happen because of several reasons. Wrong choice of drug. I told you that epilepsy is of different types. If the choice of medicine is wrong, it is not going to control epilepsy. It might actually worsen. Irrational combination, inadequate dose. We pediatricians, we decide the dose based on child's weight, and it has to be precise and exact. So inadequate dosing at times is responsible for poor control. Insufficient duration, poor drug compliance. It means the parent is giving the drug for 2-3 days, skipping doses because of whatsoever reason. So there might be breakthrough seizures. And the last reason is non-epileptic event. It is not epilepsy only that you are trying to treat. So it cannot be controlled by your epilepsy medicines. So I have told you that there are several movements which look like seizures. So whenever there is poor control of epilepsy, we need to go back and make sure whether what we are dealing with is actually epilepsy. Next please. So what are the options? We have one option of medical management. Supposingly if we have exhausted that option, we have the option of dietary therapy. There are few special diets that the child can be started on apart from the medicines which can help in controlling the epilepsy. These special diets, they change the substrates or chemical activity in the brain and they help in controlling the seizures. This actually is very useful, and we have published research on the use of dietary therapy across several countries, and it has been now proven that it is highly useful. The other option is surgery. Sometimes when there are structural problems in the brain, we can go ahead and do epilepsy surgery. One perplexing question is what to do if the child has seizure at home. What first aid should I provide? That is very important. First thing is stay calm. Don't get panicked. Stay with your child. Try to note the time when it starts. Why? Because at times when you are worried, even a second looks like minute and minute looks like hour. So when you need to go back and tell your doctor that the seizure lasted for 5 minutes, you should have some rough idea as to how long the seizure lasted. In that moment of panic, if you can just approximately tell us what is the time duration of the seizure, it can be useful. So what you need to do, first of all, loosen any tight clothing. If there is any tight clothing, just loosen it. Make the child lie on one side with the head supported either by his own hand or by a soft pillow or any other soft cloth. This will help in preventing the injury to the head while there are jerky movements. At the same time, keeping the child on one side will prevent any aspiration or the contents of saliva and mouth going back into the windpipe. It will prevent. Try to move the child away from furniture and sharp edges. So make sure that the child is placed in a safe environment. And sometimes you notice a lot of frothing in the mouth and in the nose. You try to wipe it off. So this positioning is very important. Our idea is to prevent injury and prevent the contents entering the windpipe and choking. So we are trying to prevent this by placing in this position. If there is an infant, you can hold the child in this position. You are holding it on one side and with the head placed slightly low. So this simple, this first aid begins with simple position. Next, please. What you should not do is do not panic. Do not try to restrain the child by holding him tight. That is not going to stop seizure. Do not attempt to put anything in the child's mouth. It is a usual tendency to try to insert finger, try to insert a metallic spoon. That is only going to injure the child's mouth and teeth. Please do not attempt to do that, right? And do not try to give the medicines through the mouth when the child is actually having a fit. That may choke the child, right?
People try to give water also.
Water also, as if it is going to stop the seizure. Please do not attempt to do that, right? There is medicine available in the form of a spray, nasal spray, which means it needs to be put in the nostrils to stop the seizure. This is known as midazolam nasal spray. You can discuss this option with your treating doctor, who can tell you the dose of this medicine to be given when the child has a fit at home. Right? So we shake this spray before use, and we place the tip of this nozzle in the child's nostril, and we count and spray the number of puffs depending on what is the dose advised by the doctor. This can be very useful. It stops seizures in 80% of the cases while the child is trying to reach the hospital. So this can be very useful during emergencies.
Excuse me, sir. This has to be given immediately or after some time?
Yeah, this is a very good question. I was coming to it only. The natural tendency of a seizure is that it would stop by itself in 1 minute. So the data is that around 30 to 40% of the seizures stop by themselves in 1 minute. 60% would stop in up to 3 minutes. If the seizure continues beyond 3 minutes, it is very much likely that the seizure will become very prolonged and is likely to cause damage to the brain. So, first thing that you need to do is place the child in the recovery position that we have discussed. If the seizure lasts for more than 3 minutes, it is very much likely that it is going to damage the child's brain or it is going to get more prolonged. It is at that time that you should definitely use the spray.
One more question. My son is epileptic. Now usually if the seizure starts with rolling of his eyes, he will have a confused stare and then his breathing will not be a normal breathing.
Yes.
And gradually after a couple of seconds he will have a jerking moment and then it will stop. Now from breath rate, what time shall I start that is?
Yes.
Because usually when I write it down, if it's just a confused stare, shall I consider it?
See, it is, although the data tells us this, practically it is very difficult to measure the duration of seizure. And it is very difficult to make out as to when the seizure actually started. Because at times, as she said, the seizure can start very subtly. That means just a rolling of eyeballs, minor twitching of the angle of mouth. So very difficult to notice and therefore to know when the seizure actually started. So whenever you have this doubt, use it. If you are unsure about when the seizure started and unsure about how long it has lasted, use it. Right?
Oh, excuse me, but that is only if it's greater than 3 minutes. If it's below 3 minutes, we don't need to use it, right?
As I told that 60% of the seizures would stop by themselves within the first 3 minutes. By themselves, even without medicine.
So 60% of the cases, sorry, we won't need to use it, right?
We will not need to use it. That's it. Next.
just one simple. Many times the child might be throwing seizure when he's eating something or has something in his mouth. So whenever a child has seizure, that means he's not conscious. So he can choke on what he has in his mouth. So anything visible, just please ensure you remove it from his
Yeah,
mouth.
at times choking can happen because the child loses consciousness when there is a seizure. So if the child is eating, as madam said, you should try to remove the whatever other contents in the mouth
Which are
to
visible.
prevent choking. So the next question is, for every seizure, do I need to take the child to the hospital? Because if you have put the spray, the child's seizure is stopped. Now should you take the child to the hospital? This is one confusing question. So we have put these conditions in which you should bring the child to the hospital. Supposingly it's the child's first seizure, you should bring to the hospital. Why? Because we need to evaluate why the seizure happened. What are the chances that it will happen again? Is there a need to start the child on medicine right away? So to find out the cause in the first seizure, you need to bring the child to the hospital. Second, if the seizure lasts for more than 5 minutes. 5 minutes is a sufficiently long time to damage the brain and for the chance of the seizure to get more prolonged, lasting for hours also. So if the seizure lasts for more than 5 minutes, bring the child to the hospital. If there is any head injury, please bring the child to the hospital. Any difficulty in breathing, which remains even after the seizure stops, you should bring the child. Or there is persistent blueness of lips, which tells me that the breathing is not enough to ensure proper oxygen delivery. You should bring the child. Or if you are unsure that the child is well, then you should bring the child. So these are the situations where you should bring the child to the hospital if he or she has a seizure. One very common subtype of seizures, one type of seizures I have tried to cover because this happens to be the commonest. This is what we call as febrile convulsions. So children in this age bracket from 6 months to 5 years, they have a tendency to throw fits when they have fever. Usually these seizures are short and the child usually gains consciousness as soon as the seizure stops. It is not an epilepsy by itself. What I am trying to say is that those children who have only simple febrile seizures, they are unlikely to have the behavioral and learning problems that we have seen are commonly associated with other forms of epilepsy. Usually, in a typical case of simple febrile seizure, no further investigations are necessary except for finding the cause of fever. What caused the fever in the first place? Whether it's malaria, respiratory tract infection, some urine infection. We need to evaluate the cause of fever. EEG, neuroimaging are not usually required. There are special situations in which we do what is known as CSF examination, which is a tap from the back of the fluid, it circulates around the brain. So what we are trying to do is, we are trying to know whether or not there is brain infection, brain fever, what we call meningitis. So in children who are between 6 to 12 months and who are not vaccinated for H influenza, B vaccine and pneumococcal vaccines, we do CSF examination. So what should you do when the child has febrile seizure? First try to give the tepid sponging, try to bring down the fever. Ask your doctor if there is a need to give one medicine for 3 days at the onset of fever to prevent seizures at the time of fever. And few children, despite this, can have multiple episodes. They need to be put on long-term daily medicines, but that decision is to be taken by the treating doctor. As I told you, the long-term risk does not exist for simple febrile seizures. Long-term risk of behavioral problems, learning problems, and long-term epilepsy does not remain a risk for simple febrile seizures. There are few other aspects that over the years I thought that are some questions which do not come to one's mind that easily, but they have effect on everyday life of the families of children with epilepsy. So I have tried to cover these 2-3 aspects. Yes. What about schooling of these children? Are they capable of normal schooling? So most children with well-controlled epilepsy have normal IQ. Those children in whom the epilepsy is partially controlled can still have normal schooling with proper communication to the teachers. They should always carry a seizure card, and the teacher should be aware of the child's condition. And we have come across incidents and events whereby a child has been refused admission in schools just because he or she has epilepsy. I think this is highly discriminatory, and there is no such place for such acts and activities in the 21st century. One cannot discriminate on child schooling based on epilepsy. So this message I wanted to give just in case you happen to face similar problems. Next please. Next is sports. How much should we allow the child to participate in active sports if he has epilepsy? If the epilepsy is well controlled, he can participate in sports. If the epilepsy is not well controlled, try to avoid unsupervised swimming. We have seen episodes of drowning occurring when the child is swimming unsupervised and has a fit while swimming. So be careful about that swimming aspect. Likewise, even with a bicycle, ensure that the child is wearing a proper headgear and helmet to prevent any head injury if there is a seizure. Contact sports, if the epilepsy is well controlled, he can or she can participate in contact sports, but all these activities preferably should be under some supervision. There should be some adult supervisor. Yeah, I covered these 3 things also: insurance, employment, and driving. So the problem with insurance is that as soon as you declare that the child has epilepsy, the insurance would not cover any damages or accidents which occur because of epilepsy. So we need to, therefore this is one more reason that we should insist on the epilepsy being well controlled. Epilepsy in India as per law does not fall into the disability category, which means physically or mentally handicapped category, and its benefits cannot be derived by somebody who has only epilepsy. Employment can be barred for only those people with epilepsy which require a fit person for employment. Somebody in the armed forces, somebody as a pilot or a railway driver. Apart from that, all office work can be done by the person with epilepsy. So employment opportunities are as good as normal people. Are you aware of this term SUDEP? SUDEP? So this is the short form for sudden unexpected death in epilepsy. So 1 in 1,000 people every year die suddenly, what is known as SUDEP, and they were suffering from epilepsy, but no cause could be found on autopsy. So what is the reason that sudden unexpected deaths occur in epilepsy patients? It's because seizures are believed to cause some irregular heart rhythm also, or perhaps the patient has suffocated because of impaired breathing while the person had a fit during the sleep. So please. Go ahead. So it is very important that we prevent these deaths of epilepsy patients which occur suddenly without warning. The best way to do it is by controlling the epilepsy. So giving the medicines regularly, addressing all seizures, using the first aid and midazolam nasal spray whenever there are seizures. By doing these simple things, we can prevent deaths. Next, please. My last take-home message is trying to demystify epilepsy, removing the myths and establishing the facts. So as I started with, epilepsy is not some possession by evil spirit or wrath of God. It is a neurological disorder. It can be controlled by medicines. It is not infectious or contagious in nature. And a person with well-controlled epilepsy can live a normal productive life. It's not that all persons with epilepsy would be mentally retarded. That's not true. And one more thing that we see in adolescent female patients is that they have this fear that women with epilepsy can't have children, so they should not get married. That's very wrong. Most women with the well-controlled epilepsy, they can safely conceive, and their rights to marry are as good as others. So with this small message, I conclude my talk. I hope it has created some ray of hope in terms of information and applying and spreading this information to the people and the families of children with epilepsy that you come across. I thank you all for your valuable time, and I thank Prachi ji and Rahul ji from Nai Disha for making this possible, apart from my team headed by Dr. Shivaranjani madam. And I welcome any questions for the next half an hour or so if there are any.